Hello and welcome to the Voices of Healthcare Equity podcast. I'm your host, Kim Tranquata. I am the founder and CEO of Healthcare Alliance for an Equitable World and a board certified emergency physician. With this podcast, Voices of Healthcare Equity, we are building a community. This podcast will feature conversations and insights from innovators in global equity. And through those insights and perspectives, I am inviting you to join us in this community and in our mission to make a lasting and scalable impact on global equity in our lifetime. Today's guest is Chandramouli Samathan. Chandra's second taping with us. I'm going to just remind everyone that we do have part one with Chandra, where we spoke about COVID as a driver of change in telehealth, about his development of the CARE platform and the CARE app, CAARE, and developing the rural blueprint for providing telehealth by through this app in India. Also, we spoke about Chandra's collaboration with the National Health Authority and getting digital mission certification in India. And so I'd like to pick up our conversation today with asking you, Chandra, because you are very busy and very much in the growth stage as an entrepreneur. What is CARE? What are CARE's newest projects and goals?
Yeah, thank you, Kim, again for the opportunity. So right now, we've recently started our first digital clinic. So where basically we are talking about a hybrid model where a doctor is sitting in a primary clinic and all the specialist consultations are done through telemedicine, right? And we believe that is the right solution going forward, and because the acceptance and the adoption is also very good, because it's going to address a lot of the barriers typically we find it in the rural areas with regards to telemedicine and the other things. Probably I can elaborate more. So we are going with that concept, and we are in the so we started first clinic. We are second clinic is being set up, and we are in the plan to start at least five clinics by the first quarter of 2024. And this model uh, will be built along with the top hospital networks and foundations, and that is through on a CSR model, like more of a corporate social responsibility model. But parallelly, we are also building another sustainable healthcare model, uh, which we believe is going to be the future, where uh, it will not be a heavy on the pocket for the rural communities, but also gives them access to quality healthcare from those digital clinics. So yeah, we are fully into this initiative, and we are hoping to open a lot more clinics in the coming year.
That is excellent and amazing. So perhaps you can tell us more about this sustainable healthcare model. It's definitely a challenge to have a business that is new and growing, and you are indeed trying to provide healthcare to the poorest communities. So, who pays for this, and how do you make it sustainable?
So what we have done is we have obviously worked on different uh, revenue models. So the way we have built is what we have understood is telemedicine or telehealth cannot be a single source of revenue, because that will never help or will not help us sustain in the market. Ideally, we have to bring in other partners, or I would say other systems, into an integrated model. So what we are attempting right now is with our digital clinic model, uh, we are not only offering the patients primary health care, we are also enabling the specialist healthcares from those centers itself, so that obviously the cost of traveling and the wait time, so all that is reduced for the patients. uh, Additionally, we are also trying to do a lot of the diagnostics at the center itself. So as you know, we have partnered with Abbott and a few other diagnostic companies. So we are able to secure their advanced devices and their point of care devices, which helps us um, almost do like 60 to 70% of the diagnostic tests right at the center, without uh, not having very like not requiring a pathologist or somebody very senior profile to do that, because these devices are can be operated by a health worker, right? So we are able to bring those components also into the entire model. So thereby the diagnostics are taken care, the healthcare, or I would say consultations are also taken care. uh, Even the medicines, we are partnering with some of the pharmacies nearby, so that we can also make generate some revenue through them. And obviously the longer term is uh, refer them to the respective hospitals for advanced care. So by bringing in all these components, I believe we are able to sustain and also generate revenue. And with regards to generating revenue, we are charging probably less than $1 for primary consultation, and slightly over $1 for the specialist consultations. And uh, and also we are seeing a lot of traction with the model, because as you know, telemedicine itself is something which is very alien to most of the rural communities, and they are not very comfortable. So what we are trying to do is we're trying to bring in a primary health doctor, a physician who's probably graduated and he's come out of a college, or he's got 1 or 2 years experience. So we are basically positioning them in those clinics, enabling to provide primary care from those centers. So they build a relationship with the patients, and as we grow, all their problems with specifically with the specialist requirements, specialist doctor requirements, so we are able to enable that from those centers itself. And so that way we are able to generate some revenue there, generate revenue through diagnostics and through other referral systems. So that is how we are building a sustainable model. So we have seen that it has the ability to help us become positive, cash positive, and after some time it can also bring some profits. I mean, may not be great, but at least uh, help us sustain and make some profits in the coming years.
That's sounds very much like how a modern healthcare uh, facility generates its revenue. It's not just the services being provided to the patients, but the pharmaceuticals and the testing. Now, what's unique about the environment you're working in is that India has a universal healthcare system. And I'll ask you, um, does that universal healthcare infrastructure pay for most of these things, the diagnostics and pharmaceuticals? Because, of course, that becomes a barrier for the patient as well as you if you don't have that source of revenue.
So right now, what the government offers is to the patients, mostly to below poverty line, is an insurance scheme which they call as Pradhan Mantri Jan Arogya Yojana. So which has a cap for a family for like 5 lakhs for a family, and for any kind of illness or issues, obviously they can get hospitalized and avail those benefits. So beyond that, they don't get any specific insurances on, say, OPD consultations or dental, or so such options are there, but not there. And unfortunately, there are a lot of middle class and lower middle class. Many of them don't have insurance, and they spend a lot of money from their pocket. And we have seen many cases where literally many of them have actually um, they have actually uh, they were brought down to below poverty line because of the cost of the healthcare, right? Because somebody in their family has undergone a surgery and they have to kind of sell everything to pay them, right? Pay for their services. So those things are there. So that is the reason. Even though insurance and other schemes are available, but again they are limited to very small section of the communities. A lot of people are still outside that bracket, so they don't get those services. So our model fits in very uniquely there. What we are trying to do is not only in the rural, we are also looking to focus on urban poor, right? Because a lot of people who migrate from these villages and start exploring, or I would say finding jobs in urban areas, and for them again it's very costly to avail these healthcare services from the cities. So with our model, again, we can give them that a subsidized model, which is probably one fourth of what they pay at a regular center.
Um, the economy is an interesting place and can be competitive. Do you have any concerns or have you run into any resistance from local healthcare providers that you might be undercutting their services with your service?
So far, no, but I believe that is a possibility as we grow and expand. Right now, everybody obviously looks at more with an open heart. But again, eventually, as we grow, because our model, we believe, is going to probably affect most of these unqualified doctors who still continue to run their businesses and treat people in the community. So it might affect them, and so probably there might be a friction, but yeah, I don't think that is a challenge.
And how are you finding patients receiving the price bracket of your services? And are you seeing any impact on increase use of healthcare services in the regions that you are servicing?
Yeah, so I mean, typically, like earlier, what used to happen is when we were conducting camps, and I would say most of the time it is like one time care provided to them.
So, could you tell us a little bit about who you use to be the providers for your service on care and how you recruit and get the involvement of these people to provide the consultations and the specialty care for your rural communities?
So the approach we are taking is we are reaching out to I would say big hospitals, and then we are pitching our solution to them, stating that this is a satellite clinic we are opening in these areas, and we are doing these primary consultations, and and we would need your support in enabling specialist consultations for these communities, which will also in turn help your obviously business as well, right? So any referrals from this we can be made to your respective hospitals, and your brand penetration will also happen in these rural communities, and your brand can also pull the crowd for us in a way. We can say that uh, from our rural center now we have access to these top doctors coming from this particular hospital, right? So it's a win-win for both of us. Your brand awareness in the market, and your penetration into these regions. So I think that's like a win-win situation for both the entities, and that's how we are pitching in. And so a lot of these, I would say, multi-speciality hospitals, which are based out of cities, are willing to offer and cooperate.
That's amazing. I would like to ask, is there any aspect of folks feeling like this is extra work and they don't want to engage in this? And if there is, maybe you can tell us about that. But if there isn't, what do you think affects them not having that reaction?
So I think one of the key thing when we started approaching these hospitals, even though the owners of the hospital are very keen and willing, when we reach out to the specialist doctors who are super busy, they literally give you just 2 minutes of their time to speak to us as well. So the challenge there was obviously we had convincing them, but after they understood the platform and the approach, they are very keen, and they kind of adopted to what we are saying. So ideally what we told them is that uh, you as a specialist doesn't have to do a lot of work, because somebody at the rural clinic, a doctor himself, he's preparing the patient, ensuring they give you access to all their medical records, and there is a doctor in the clinic, in the rural clinic. So your job becomes very easy for you, because the challenge for specialist doctors is to speak to patients, understand their problem. They spend a lot of time in that conversation itself. So that is totally eliminated. The doctor can be very specific to what the problem the patient is facing, and the specialist doctor can quickly recommend what to be done as the next step, and then they can simply prescribe a medicine. And for that also we made it very simple, that they don't have to make or entry like typing the prescription. Instead we said you can just write it on your prescription pad, and then take a picture and just upload it in a second, right? So the whole model seemed very convincing, because for them, I mean, it's not that they don't want to talk to patients, but because if they talk to patients, they spend a lot of time, right, to understand their problems. So here they obviously recognize the patients there, but the interactions happen with the doctor, so that simplifies the job for them. Thereby the time is optimized, and they are also open to that model.
Are your rural primary care um, clinicians all physicians, or do you have different levels of healthcare training, like community healthcare workers or nurses? Are they always interfacing with the doctor?
So each clinic has I would say, a primary doctor, health worker. So ideally, she is an A&M or a nurse, or and one assistant, so who's more of a community health worker. So it's a team of three people based in that clinic. So I think that is a good size to kind of make things easy for everyone. So that, I mean, one is managing the registrations, the nurse is managing all the vital checks and everything, and the video call consultation, and the doctor obviously is able to prescribe medicine, I mean, talk to the patients. So those things are happening very seamlessly, and they are not finding it very challenging. Um, and again, whenever there is a specialist consultation requirement, so obviously they will tell the patient that on this particular day you have to come back, and that way the time management is also taken care of, right? Because they are booking the specialist consultations after the initial primary checkups are done by the doctor there, and he thinks that this patient needs a specialist consultation, so he'll book an appointment accordingly based on the specialist doctor availability. So that way I think the whole scheduling is managed, and the specialists are also intimated prior to the consultation that there is going to be a consultation at this time. All the records are all already given to them prior hand, because already the first consultation did happen with the primary doctor, so they have all the vitals and the initial information with them, and they've uploaded that. So whenever the doctor finds time, he can kind of look at those documents and join the call at the time of the consultation, and then probably just spend 5 minutes, I think max to max 5 to 10 minutes, and then and that'll be done. Based on what they find, they can prescribe medicine, yes, and they can close the call.
That's excellent. And a really important part of making this sustainable in any healthcare infrastructure is the willingness of insurance and the willingness of the healthcare system to pay for these consultations by telehealth. Is that already in place where you are working in India, and is it universal?
So not right now. So uh, currently, we are trying to explore some models with the insurance as well, and uh, we are hoping we can do something like that in Philippines. So we are exploring that opportunity there, because again, Philippines has their own Phil Health national wide insurance model where. Uh, I mean, government is going to pay for all the consultations, like even for telemedicine or primary consultations and medicines and diagnostics. Everything is taken care of by them. So all we need to set up a primary clinic. It could be a telemedicine clinic itself. So that is there in those regions, and we are working aggressively to build our model there as well. But coming back to India, we don't have it, but once we grow, we set up more and more clinics. So we would like to probably talk to some of the insurance companies, probably help us, uh, probably provide a model where all our all the communities can actually avail those services, right? So that is our idea, but right now there is no insurance in place.
Excellent. So these specialists that are consulting for you are really doing it for non-financial gains, such as brand penetration and increased referrals, and less for um, reimbursement for the consultation.
Yeah. So again, as I said, there are two models. So in one, which is driven more on a CSR agenda, so there the consultations are made free of cost. Even the specialists who are getting involved are also providing the consultations free of cost. But the other sustainable model where we are going to generate revenue, we are willing to pay even the specialist, but not the regular price, or I would say cost. We are looking to kind of bring down those costs, and then at least provide a fee for their services, because again, it may not work in a longer run to get free services, right? Like they might help you for a couple of consultations, but not continuously. So we want to build a model where we pay everyone who are providing the services, but at least a very subsidized rates.
Understood. Right now, it sounds like you have a lot of very custom clinic relationships with the local referral center. And I wonder, I want to ask, maybe now or as you grow, are there any issues or needs for translation services? India is a very big country with different dialects and many languages. Have you run into that issue, and is that something that you have built into your model already?
Yeah, so again, I think our model itself addresses that the very challenge of the dialect, because um, the health workers and the doctors based out of these rural clinics are localites, so they understand the local language, and when they communicate and talk to these patients, they obviously converse in their native, or I would say, mother tongue. So that way, patients are not really feeling, or I would say, are not finding it difficult to converse, and even the doctors who are onboarded are from the nearest, I would say, hospital network, and they are also from the same region. So again, we don't find that as a challenge. But even if we are trying to bring doctors from a different state altogether, like maybe that state speaks completely a different language, but the good thing about this model is that the doctors from the rural in the rural clinic are always from the same community, right? People basically they have to physically go to that center every day, sit there and provide services. So typically they are from the same community or from the same region. So that way, even if there is a specialist coming from a different I would say state, and if they don't understand the specific local language, but at least a common language like English and Hindi, which they can talk, and the doctor is in the local community, they understand that language and they can translate that to the patient based on what they hear from the specialist doctor. So we're not finding that barrier as yet, but and as a model itself, I don't see that becoming a challenge also in the future.
I want to ask one more question as we go into our break. Is it fairly universal for doctors across India to speak both English and Hindi? You said that's a common language shared by the physicians.
Yeah. So all of them speak English, and most of them speak Hindi. So some of them have some difficulty in speaking Hindi, but all of them speak English because our, as you know, our education system is mostly English, and that too when you maybe the schooling is done in regional languages, but when you graduate and kind of do advanced degrees, and mostly they are all English, right? So all the doctors who are graduated and all the specialists, they speak very good English, and even the doctors for that matter. But most of them also speak Hindi, the, I would say, national language of India.
Excellent. That's very useful information. Thank you, Chandra. We're going to take a little water break now. Thank you for joining us in this week's episode of Voices of Healthcare Equity. Together, let's amplify this conversation for a healthier and more equitable world today.